Hello everyone. Thank you for joining us today. We have with us Dr. Rohan Khandelwal, who is surgery faculty at Marrow. And today's topic is discussing the images. And Sir will be taking the session where he would be discussing the important images and some concepts related to those. Please stay in tune and over to you, Dr. Rohan.
Thank you very much, Arvind. Good evening, everyone. I hope all of you can hear me and see the slides. And I hope all of you are keeping fine. Now that the exam date is also out, I think so you would have more direction to your preparation and you can plan your preparation well. One thing which I noticed in the last exam was that there were a lot of image based questions. In surgery alone, there were close to 30 to 35 image based questions. And that is why I wanted to cover these important images in two or three parts so that you can note them down and you can retain them for the exam as well. As always, once the session is over, tomorrow we will share the PDF of these slides so that you have the images with you for further exams and for future preparation as well. I will only be taking questions at the end of the session. First, I'll be showing you images and then I'll be briefly talking about your strategy for the exam. And if you have any questions at the end, I'll be happy to answer them. So, without wasting any time, let's start with the images. In case you need to contact me further, this is my Instagram ID, left handed surgeon. You can always drop me a message there. So, images are very important for the exam. Look carefully, try to make as many notes as you can. We will share the PDF with you by tomorrow. Okay. So, first, we're going to start with thyroid and common questions asked in thyroid disorders. They always ask what is the initial investigation. The initial investigation are thyroid function tests, that is T3, T4, TSH. So, any patient with thyroid disorders, we will do the thyroid function test first. The investigation of choice, mind you, is fine needle aspiration cytology. So the full form has been asked FNAC, and they've also asked what is the size of the needle used. So the size of the needle used is 23 to 30 gauge. Please remember that that has also been asked in the exam. One drawback of thyroid FNAC is that it cannot differentiate between follicular adenoma versus follicular carcinoma. That differentiation cannot be done. A normal thyroid scan, the indications are when there are features of hyperthyroidism with low TSH, or you have ectopic or aberrant thyroid tissue, or you have ectopic or aberrant thyroid tissue. That is the other indication for a thyroid scan. This is a normal thyroid scan. You can see that both the lobes are shining equally, both are showing equal uptake. Let's see the abnormalities in thyroid scans, and these have been asked in all exams, FMG, PG exams, all exams this has been asked. You can first see a non-functioning or a cold nodule. You can see that the entire gland is taking up the dye or the contrast, but there is one nodule which is not taking up any of the iodine. So that is a non-functioning or a cold nodule. A nodule not taking up the iodine is a non-functioning or a cold nodule. And mind you, cold nodules have a higher risk of malignancy. So 20% cold nodules are malignant. Whereas if you see the image below that, you can see a hot or a hyper functioning nodule. What has happened is that only one nodule is taking up all the iodine, the rest of the gland is showing very less uptake. So that is a hyper functioning, more uptake, and that is a hot nodule, only 4% risk of cancer. In Graves' disease, you can see there is diffuse increased uptake. It looks almost like a normal scan, but the percentage of uptake is higher. Autonomous nodule is when only one nodule is working, the other nodule is the other gland, rest of the gland is completely suppressed. Now, if you have multiple hot and cold nodules, that is a toxic multinodular goiter, also known as plumber's disease. So, toxic multinodular goiter is also known as plumber's disease. Another question which has been asked in your exam, that in thyroiditis, you get diffuse decreased uptake. So this thyroid scan slide is extremely important. Lots of questions have been asked. Again, to reiterate, when uptake is not there, it is a cold nodule. When you see more uptake in a single nodule, that is a hot nodule. A thyroglossal cyst, it is a remnant of the thyroglossal tract, and it usually presents as a midline neck swelling, right? Midline neck swelling. The characteristic feature of a thyroglossal cyst is that it will move both on deglutition and protrusion of the tongue. Because it is attached to the base of the tongue, even when protrusion of tongue is done, this swelling is going to move. The most common location has been asked in your exam. It is infrahyoid. And please mind you, surgery is not incision and drainage. Asked many times, it is not incision and drainage. It is cyst trunks procedure. Cyst trunks procedure is when we remove the cyst along with the tract right up till the base of the tongue, and part of the hyoid bone is also removed. So entire swelling, tract right up till the base of the tongue plus part of hyoid bone. This image has been asked in your exam. So a trend this year in the exam was that they were giving a brief history and an image. So you could come to the diagnosis with either one. Now this is very clearly evident. You can see multiple nodules. So it's a multinodular goiter, right? And the surgery which is done for a multinodular goiter these days is total thyroidectomy. Total thyroidectomy. This one is a diffuse goiter. Diffuse goiters can be seen during puberty, during pregnancy, when the demand is higher, in Graves' disease, in Hashimoto's thyroiditis. These are conditions where diffuse goiter can be seen, where you can't see nodules, there is just diffuse enlargement. Again, the surgery of choice, if there's diffuse enlargement as well, would be total thyroidectomy. This sign has also been asked in the exam. This is Pemberton sign. Pemberton sign is seen in patients with retrosternal goiter, and this is seen in patients with retrosternal goiter. That means when the goiter goes behind the sternum into the mediastinum. And this sign is when you ask the patient to raise his or her hands, there will be facial congestion seen. So facial congestion is when you ask the patient to raise his or her hands. Now, mind you, a very important question which has been asked in the exam, that majority of the retrosternal goiters can be removed via which incision? Via the neck incision alone. So because majority are secondary retrosternal goiters, right? Secondary retrosternal means they start in the neck and then they go into the mediastinum. They can be removed via the neck incision. This has been asked many, many times in the exam. These are the various types of thyroid surgeries, and these descriptions of thyroid surgeries have been given in Bailey, and you should know about them. These descriptions you should remember. So, hemithyroidectomy is the minimum surgery for thyroid, and mind you, hemi is lobectomy plus isthmusectomy, right? Total thyroidectomy is when you remove the entire gland. Subtotal is when I remove majority of the gland, but on both the sides, I will leave some amount of thyroid tissue, right? That is subtotal thyroidectomy. Near total thyroidectomy is when one entire lobe, the isthmus, is removed, majority of the other lobe is removed, only some amount of tissue is left on the other side. So that is a near total thyroidectomy, also known as a Hartley-Dunhill procedure. Okay, so these are the four thyroid surgeries. Minimum surgery is hemithyroidectomy. You should also know that the incision used is the collar incision, right? The collar incision, which is 2 finger breadths above the suprasternal notch. So collar incision, which is 2 finger breadths above the suprasternal notch. This instrument, and I'll be talking about a lot of instruments today. I'll show you a lot of slides of instruments. This is a Joel's thyroid retractor. which is used during thyroid surgery. And another question which has been asked in the PG exam is that how many Joles retractors are required? So you need one on each side. So two Joles retractors are required during thyroid surgery. This is also an important slide. This is minimally invasive video assisted thyroid surgery. Minimally invasive video assisted thyroid surgery. The same can be used for parathyroid as well, right? And the most common approach you can see here, it is almost like doing laparoscopy for the thyroid gland. And the most common approach is the transaxillary approach. You go via the axilla. So it's a transaxillary approach which is preferred here. So I have already told you, don't worry. All those who have registered, who are listening to the session, will be getting the PDFs tomorrow on your registered ID. So try to make notes, try to write down the important points. Otherwise, all these slides, the PDF, you will be getting tomorrow. Okay. So try to understand, try to remember the concept. That is more important. You can always brush through the slides once more when you get the PDF. Okay. These two signs, many times in the FMG, PG exam, they've been asked. These are signs of hypocalcemia. Trousseau sign is a carpopedal spasm. When you inflate the BP cuff, the hand goes in spasm. This is carpopedal spasm. And a question which has been asked in the FMG exam is this is also known as obstetrician's hand deformity. If you've taken a delivery in the labor room, you'll know why this is known as obstetrician's hand deformity. So, obstetrician's hand deformity. Schwastig sign is if you tap over the facial nerve, there will be facial spasm. And both are severe signs of hypocalcemia, which can be seen after thyroid surgery. This is exophthalmos, which is commonly associated with Graves' disease. This is an eye sign associated with Graves' disease. You should be able, this is a spotter, you should be able to pick up this image easily. This was one of the questions which was asked in the FMG exam, and I thought it was a very good question in the last FMG exam, where they had asked that these type of skin lesions are seen with hypothyroidism or hyperthyroidism. So more common in which one? Now, students sometimes get confused because this condition is known as pretibial myxedema. Now, myxedema, you start associating it with hypothyroidism, but in reality, this is more common with hyperthyroidism or Graves' disease. So, more common with hyperthyroidism or Graves' disease, pretibial myxedema. These slides have been asked umpteen number of times in all possible exams. This is papillary carcinoma thyroid, which is the most common thyroid cancer. The risk factor is radiation exposure. Diagnosis is by FNAC. And the classical histopathological features of papillary carcinoma thyroid, you will get orphan aniide nuclei, right? Orphan aniide nuclei, which are clear nuclei, samoma bodies, which are foci of dystrophic calcification. So these bluish bodies, which you can see here, which I've marked as well, these are samoma bodies, which are foci of dystrophic calcification. And you can see intranuclear inclusions as well. Another common question asked in pathology is where else or in which other tumors do you see samoma bodies? So, samoma bodies can also be seen in serous cystadenocarcinoma of the ovary, papillary renal cell carcinoma, meningiomas. These are some other tumors where you can see samoma bodies as well. Follicular carcinoma is the second most common thyroid cancer. Long-standing multinodular goiter is a risk factor. So very important clinical scenario for your exam. Patient with long-standing multinodular goiter shows sudden increase in size. Now, a lot of students, because of the sudden increase in size word, they get confused with anaplastic carcinoma. No, if there is a multinodular goiter and sudden increase in size, it's more likely to be a follicular carcinoma. Okay. Anaplastic carcinoma, the age group is different. It would be seen in the fifth or the sixth decade of life. I have told you that FNAC cannot differentiate between adenoma versus carcinoma. So the minimum surgery in such a patient will be hemithyroidectomy, and that's how we will come to the diagnosis. Medullary carcinoma thyroid. This arises from the parafollicular or C cells. These cells are the ones which secrete calcitonin, and it can either be sporadic or familial. And the typical clinical scenario which you will get is a patient with the thyroid swelling. FNAC is done, and FNAC reveals a myeloid rich stroma. So these are the key words which you need to listen to. And please remember that in your exam now, whether it is FMG or PG exam, always focus on these key words. If you can identify these key words, you can quickly reach to the correct answer. So a myeloid rich stroma, this pinkish material which you can see, is classical of medullary carcinoma thyroid, which can either be sporadic or familial. The familial one is seen in MEN2 syndrome. So those were the slides on thyroid disorders, the images which I want you to know. Moving on to oral carcinoma, which is also a very important and a frequently asked topic in the FMG exam. So you should be able to differentiate between candidiasis and leukoplakia. If you can see the above image, candidiasis, you can see a hyperemic border. You can see this reddish border. And candidal patches can be rubbed off. You can rub them off. Leukoplakic patches are white patches which cannot be rubbed off. You can see here this white patch which cannot be rubbed off, and it increases the risk of cancer by 3 to 6 times. This is erythroplakia, and erythroplakia is a red patch. This one is a proliferative varicose erythroplakia. It increases the risk of cancer by 6 to 9 times. Again, like leukoplakia, erythroplakia also cannot be rubbed off. This is oral submucous fibrosis, which is a hypersensitivity reaction to products of betel nut. So betel nut or areca nut can cause fibrosis, because of which the patient cannot open his mouth completely, right? There is restriction in mouth opening. That leads to poor hygiene and increases the risk of oral carcinomas. A very common mistake made by students, they think that if it is fibrosis, if you cut the fibrous tissue, patient will have mouth opening. But if you cut the tissue, how will the body heal? The body will heal with more fibrosis. So the treatment of choice here is intralesional steroids or intralesional triamcinolone. Please remember this. This question has also been asked many times. Plummer-Vinson syndrome, also known as Patterson-Kelly-Brown syndrome, has also been asked many, many times in the exam. Plummer-Vinson or Patterson-Kelly-Brown. You can see that patients will usually have iron deficiency anemia, angular stomatitis or glossitis, and dysphagia due to post-cricoid webs. This condition is more common in perimenopausal women, and it increases the risk of hypopharyngeal cancer and squamous cell carcinoma of the esophagus. So the two cancers where there's increased risk with this condition are hypopharyngeal cancer and squamous cell carcinoma of the esophagus. This has also been asked in the exam. These two one-liners and this image has been asked many times. The most common site of oral cancer all over the world is the lateral border of tongue. The most common site in India is the gingivo-buccal sulcus or the buccal mucosa. That is the most common site. The biopsy, we always take an incisional biopsy in these cases from the edge. So we will take an edge or a wedge biopsy to confirm the diagnosis. Edge or a wedge biopsy is taken. Neck dissection, the incision name has been asked in the exam. This is modified Schubinger's incision, which is used for neck dissection. This has been asked many times. This is a summary of neck dissection. Again, there were questions from neck dissection in the PG exam. There were questions in the FMG exam as well. So you should know about neck dissection. So radical neck dissection was described by Kreil, was the surgeon who described radical neck dissection. Level 1 to level 5 lymph nodes in the neck are removed. Level 1 to level 5 lymph nodes are removed, plus 3 extra lymphatic structures. The 3 extra lymphatic structures which are removed are sternocleidomastoid, internal jugular vein, and spinal accessory nerve. In addition to this, the tail of parotid and the submandibular gland is also removed. Modified radical neck dissection, the incision used is Schubinger's incision, and level 1 to level 5 lymph nodes are removed, but we save at least one extra lymphatic structure. If you save one, then it is known as MRND1. If you save two, it is MRND2. If all three are saved, we call it functional neck dissection. That is, if you're saving spinal accessory nerve, internal jugular vein, and sternocleidomastoid, all three. Selective neck dissection is when you're removing selective lymph nodes. Central neck dissection is when level 6 lymph nodes are removed. Supraomohyoid is level 1, 2, 3, and extended supraomohyoid is 1, 2, 3, and 4. Again, I've told you that I will be taking questions at the end. I don't want to miss out on these images. First, let me cover the images. Then I'll answer your academic questions. And then if you have any general queries, I am reiterating the PDF will be shared with you. Try to make notes. Not everything is written on the slides. Just write down things, images you will get by tomorrow. This flap has been asked in all possible exams. It is very, very important. This is the most commonly used flap for head and neck reconstruction. This is pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap. That means we are going to rotate the pectoralis major and we will cover the defect which is caused after oral cancer surgery. This is a ranula. Ranula image was there this time in the FMG exam also. At least 10 times previously also ranula has been asked in the exam. Ranula is a mucus extravasation cyst involving the sublingual gland. It is fluctuant and brilliantly transilluminant. Incision and drainage should not be done. Mind you, no incision and drainage. Marsupialization or excision can be done along with the sublingual gland. A plunging ranula is a mucus retention cyst involving the sublingual and the submandibular gland. There is a swelling in the oral cavity and a swelling in the neck, and the management is excision of the intraoral swelling, the sublingual gland, and aspiration of the neck swelling. This is another new table in Bailey. This is a Staphne bone cyst, which is the most common site of ectopic salivary tissue. Most common site of ectopic salivary tissue. Again, salivary glands is a very important topic for the FMG exam. At least one clinical scenario is definitely asked. And there were some very good questions asked from salivary glands. Some were so difficult that even postgraduate aspirants could not answer them. So parotid abscess will present as a painful parotid swelling. Fluctuation is a late sign and the management is incision and drainage. While draining such an abscess, we should be careful that we don't injure the facial nerve. Silolithiasis, that is stone formation, the most common composition is calcium phosphate, and submandibular gland is more commonly affected than the parotid gland. Submandibular gland is more commonly affected than the parotid gland. And a question which has been asked in many, many exams, investigation of choice is NCCT, non contrast CT scan. Okay, mind you, non contrast CT scan is the investigation of choice at three places: salivary gland stones, head injury, and renal stones. So don't forget these three. All three have been asked: head injury, salivary gland stones, and renal stones. A parotid swelling typically will lift the ear lobule. And a beautiful question asked in the FMG exam was that how do we clinically know that there is deep lobe involvement? So we clinically know whether the deep lobe is involved or not. You just need to ask the patient to open his or her mouth, and you will see that the tonsillar fossa is pushed medially. If the tonsillar fossa is pushed medially, that signifies that the deep lobe is involved. The tonsillar fossa pushed medially signifies that the deep lobe is involved. Okay. It won't be possible for me to give the voice recording, that is not possible. But the slides, whatever is written on them, I will try to add some extra points as well that we will definitely share with you. Okay. The most common tumor of parotid gland is pleomorphic adenoma. Investigation of choice is FNAC, that is fine needle aspiration cytology. I've already told you 23 to 30 gauge needle is used. And the minimum surgery for parotid gland is superficial parotidectomy. So you should know this clinical examination point. It has been asked in the exam. This incision has been asked very commonly, and a very common question which is now being asked is regarding nerve injuries for various surgeries. So today I'll be talking about head and neck surgeries and breast surgery. What are the potential nerve injuries? That is not only an important question for FMG, but also for the PG exams. The incision used is a lazy S incision. This has been asked. It is also known as a modified Blair's incision. The nerve injuries associated with parotid gland can be marginal mandibular nerve injury. This was there in one of the exams this year. This is going to give rise to drooping of the angle of mouth. So I'm sure you must have heard one of these three gentlemen speaking: Sylvester Stallone, Jeffrey Boycott, or Sharad Pawar. All three of them, when they speak, there is drooping of the angle of the mouth. And that is because this nerve, marginal mandibular nerve, has been injured in them. Anesthesia over the beard area. So there was a clinical scenario given last year that a person shaves after undergoing parotid surgery but cannot feel any sensation there. This is because of the greater auricular nerve. And the nerve implicated in Fraze syndrome or gustatory sweating. Gustatory sweating is after parotid surgery, when the patient eats food, there is sweating over the parotid region. That is Fraze syndrome or gustatory sweating. And the nerve implicated is the auriculotemporal nerve. So, one out of these three is definitely there in all the exams. You should know about these nerve injuries. Submandibular gland, the question which was asked, a beautiful question which was asked in your exam. A beautiful question which was asked in the exam was how to differentiate gland enlargement from lymph node enlargement, because you can even have lymph nodes in the submandibular region. So we carry out bimanual palpation. Again, very important question for the exam. Cystic hygroma or lymphangioma, this was asked in the PG exam. Also in the FMG exam, it has been asked. The most common site is the posterior triangle of the neck. That is the most common site for this lesion. It is a fluctuant lesion, compressible swelling, brilliantly transilluminant. So if you shine a torch, it will shine brightly. You should also know about the other brilliantly transilluminant swellings in the body. Ranula, I told you, is transilluminant. Meningocele is transilluminant. Hydrocele is also transilluminant. So these are some other swellings where brilliant transillumination can be seen. Investigation of choice in such a child is FNAC, and the management is aspiration and sclerotherapy, followed by surgery. Another question which is slightly difficult, but you should know about it. Another question which has been asked in the exam is that if you're doing surgery for a cystic hygroma, then the spinal accessory nerve can be injured. Then the spinal accessory nerve can be injured. The other brilliantly transilluminant swellings which I told you were hydrocele, meningocele, and ranula. Cervical lymphadenopathy, this is a constant question. Every alternate year this is asked. Most common pathological cause in India is tuberculosis. And you will get a collar stud abscess, right? It's a collar stud or a cold abscess. Mind you, you always carry out anti-gravity aspiration. Never aspirate it via the dependent route. Always anti-gravity aspiration should be done, because if you go via the dependent route, it can lead to a sinus formation. Lipoma, it is the most common swelling which can occur in the body. You can get a slip sign. Management is excision. In one of the PG exams, they asked this year that lipoma in which region of the body increases the risk of sarcomatous change or malignant change, and the answer is retroperitoneal. So lipomas which are there in the retroperitoneum can develop into sarcomas later on. So please remember that point as well, retroperitoneum. The image of dermoid cysts has also been asked in all possible exams. These are cysts which are formed at the line of embryonic fusion. They are again fluctuant. Diagnosis can be by FNAC. The most common site is the outer canthus of the eye. You can see the boy with a swelling around the outer canthus of the eye. Another common site is retroauricular, but the most common is the outer canthus of the eye, and the management is excision. But before excision, always rule out intracranial extension by doing a scan. Implantation dermoid can occur after ear piercing, or if somebody gets hit by a thorn, that can form a dermoid there. That is known as implantation dermoid. This swelling was asked last time in the FMG exam, even in the PG exams, it's been asked multiple times. A sebaceous cyst is a blocked hair follicle duct. The classical finding in a sebaceous cyst is a punctum. And this is the punctum which you should look for, and that clinches the diagnosis. This is an infected sebaceous cyst. For both, the management is excision. Multiple sebaceous cysts can be seen in the scrotum or the scalp. Those are the sites for multiple sebaceous cysts. Another question which has been asked in your exam, sites where sebaceous cysts will not be seen. So wherever hair are not there, sebaceous cysts will not be seen. So palm and sole, you will not get sebaceous cysts. Carbuncle is common in diabetic patients, and the classical area is the nape of the neck, behind the neck. That is the classical area. You can have multiple pus oozing points, and we need to carry out drainage. The question which has been asked in the exam, what incision is made? We make a cruciate incision to drain a carbuncle. Degloving injury was a question few years back in the PG exam, and whatever questions are asked in the PG or the UPSC exam, are sometimes asked in your FMG exam as well, which is why I have covered the UPSC exam paper for last year. It is there on my YouTube channel. I've also covered the last few years FMG papers on my YouTube channel. Make sure that you watch those YouTube videos before you go for your exam, because sometimes you can get at least 10 to 15% repeat questions as well. So, a degloving injury is when the skin and subcutaneous tissue is stripped of the fascia. That is a degloving injury. Cellulitis can be caused by streptococcal or staphylococcal infection, and the management of cellulitis is antibiotics, limb elevation, and magnesium sulfate dressing. Fournier's gangrene has also been asked in the exam. This is necrotizing fasciitis of the perineal region. It is caused by aerobic plus anaerobic organisms, and it is rapidly progressive. It is seen in immunocompromised patients, and the management is aggressive debridement. Even after aggressive debridement, there can be high mortality in these patients. Another question, slightly difficult, but you should know about it, that two structures which are not involved or not affected by Fournier's gangrene are the testis and the urethra. So, no matter how severe the infection, the testis and the urethra are usually spared. So, these were the slides for oral cancer, salivary glands, and common neck swellings. Now we move on to slides which are related to breast disorders. And invariably in your exam, there are 2 to 3 questions related to breast disorders. So, triple assessment for a patient with a breast lump. That means 3 things have to be done: history and physical examination, then radiological tests are done. For patients who are less than 40 years of age, we will carry out an ultrasound. More than 40 years of age, we do a mammogram. The reason for this is that young patients have dense breast tissue. So, young patients have dense breast tissue, and mammography is not sensitive in them, which is why for less than 40, we will carry out an ultrasound. Please make sure that this point is clear because it's been asked many times in your exam. Histopathological tests, the investigation of choice for breast disorders is not FNAC. It is not FNAC, it is a true cut biopsy, and I'll talk about true cut biopsies in some time. This is the BIRADS score. BIRADS has been asked in your exam, even in the PG exam. It stands for Breast Imaging, Reporting and Data Systems. BIRADS is Breast Imaging, Reporting and Data Systems. It divides the reporting of any of the mammogram, ultrasound, or MRI into 0 to 6. 0 is an incomplete scan. Incomplete scan means the radiologist cannot see anything. And what advice will such a radiologist give? The advice given would be do some other imaging test. So, supposing a patient has had a mammogram but nothing can be seen, we will do an alternate imaging test like ultrasound or MRI if the score is BIRADS 0. Alternate additional imaging tests. BIRADS 1 is negative, everything is fine. You tell the patient to come back after 1 year. Routine screening is after 1 year. BIRADS 2 is benign. Again, you tell the patient to come back after 1 year. Okay. BIRADS 3 is probably benign. Probably benign was asked last year in the exam. Short-term follow-up. That means you will repeat the scan instead of 1 year, you will repeat it after 6 months. BIRADS 4 is a suspicious lesion. All suspicious lesions should be biopsied. All BIRADS 4 lesions should be biopsied. Okay. BIRADS 5, also lesions high risk of malignancy, they should also be biopsied. And BIRADS 6 is a biopsy proven malignancy. So this is the BIRADS score, you should know about this. For breast examination, the best technique is the dial clock method. I've ticked there. That is why you would notice that whenever we report a breast lump, we always write 6 o'clock, 8 o'clock, 10 o'clock. So that is the dial clock method of depicting a breast lump. The biopsy techniques, you can have punch biopsy. This is a punch biopsy instrument. It is used for skin lesions. Skin lesions like Paget's disease, like skin cancers. You can use a skin biopsy or a punch biopsy forceps or punch biopsy instrument. True cut or core needle biopsy, you can see a true cut or core needle biopsy gun. This is the investigation of choice at three places: for breast lumps, for prostate, and for soft tissue sarcomas. All three have been asked in the exam. You should also know that this true cut biopsy, which is the investigation of choice for a breast lump, a 16 gauge needle is the best size for a breast biopsy. So 16 gauge is used for breast lesions. These two clinical signs, many times they've been asked. Dimpling of the skin is because of attachment of ligaments of Cooper. Sorry. So these are the three places where true cut biopsy is done, and 16 gauge needle is the best for breast biopsy. These two clinical signs have been asked many times in the exam. Dimpling of the skin, you can see a dimple on the skin. This is due to involvement of ligaments of Cooper. Whereas nipple, if it is pulled inside, that is due to lactiferous duct involvement, right? Retraction of nipple is due to lactiferous duct involvement. Both these signs don't denote skin involvement. Please remember this. These signs don't denote skin involvement in breast cancer. Okay. So make sure you remember that point. It is not a sign of skin involvement in breast cancer. Maximum number of times this clinical sign has been asked. This is peau d'orange or orange peel appearance, where the skin appears thickened and like an orange peel. This is due to blockade of subdermal lymphatics, right? This has been asked many times, blockade of subdermal lymphatics. And if this is present in cancer, it is a sign of skin involvement. It is a sign of skin involvement in cancer. For mammography, there are two views which are done. For mammography, there are two views which are done. You have craniocaudal and you have mediolateral oblique. Two views are taken. Please remember that mammography is the best screening modality for breast cancer. It is not breast self-examination. Mammography is the best screening modality for breast cancer, not breast self-examination. You can get popcorn calcification in patients with a fibroadenoma, that is a benign lesion, also known as a breast mouse. It is mobile, right? I'll talk about that in the next few slides. In a malignant patient, you have spiculated margins and microcalcifications, spiculated margins and microcalcifications. This is a mediolateral oblique view, MLO, and this is where you will see maximum tissue. This is where you will see maximum tissue. Also, you can see here the axilla is also visualized. The axilla is also visualized in the MLO view. This is the molecular classification of breast cancer. 2 or 3 questions have been asked in your FMG exam. Lots of questions have been asked in the PG exam from the molecular classification. So it is based on gene expression profiling. Based on gene expression profiling. You should know about luminal A cancer. Luminal A is ER-PR positive. ER-PR are estrogen and progesterone receptors. ER and PR are estrogen and progesterone receptors, which can be seen in breast cancer patients. So if ER and PR, that is estrogen and progesterone receptors, are positive, We call it luminal A. It has the best prognosis and it is the most common. HER2 nu, which is another membranous receptor, is negative in these patients. Basal type is triple negative. All three are negative. ERPR negative, HER2 nu negative. This is the most aggressive and has the worst prognosis. So these are the two types for the FMG exam. This much is enough. These are the boundaries of axillary clearance. This was a case of mine where I'd done an axillary clearance. I've highlighted the boundaries. Axillary vein is superior. Thoracodorsal pedicle is lateral. Angular vein is inferior. And Halsted ligament is medial. Mind you, long thoracic nerve I've depicted here, but it is not a boundary of axillary clearance. Okay, it is not a boundary of axillary clearance. These are the boundaries which you should know for the exam. Thoracodorsal pedicle supplies the latissimus dorsi muscle. Very important image. It has been asked in your exam. This time in the FMG exam, this question was there. Patient undergoes a mastectomy and comes with this deformity. This is winging of scapula. You can see that the scapular border has become more prominent, and this is due to injury to which nerve? Long thoracic nerve. So don't forget this. This is an important image. Other nerves which can be injured in breast surgery, the most commonly injured is intercostobrachial nerve, ICBN, which is the sensory nerve to the inner aspect of the upper arm. So how will the patient present? The patient will complain of anesthesia in the region of the axilla. There'll be anesthesia in the region of the axilla. Long thoracic nerve, I've already told you, gives rise to winging of scapula. Thoracodorsal nerve supplies the latissimus dorsi, and the lateral and medial pectoral nerves supply the pectoralis major and minor. This also you should be able to identify. This is lymphedema of the upper limb. You can even have lymphedema of the lower limb. This is lymphedema of the upper limb, and post-mastectomy lymphedema is the most common cause of upper limb lymphedema. So post-mastectomy lymphedema, that is after breast surgery, that is the most common cause of upper limb lymphedema. You all know that the most common cause of lower limb lymphedema is filariasis. Right, correct. So it is filariasis that is the most common cause of lower limb lymphedema. This is another very important question which has been asked in the exam. Patients with long-standing lymphedema can develop secondary malignancy, and the secondary malignancy is known as angiosarcoma. This angiosarcoma will present as bluish or reddish nodules. You can see here these bluish or reddish nodules. And this syndrome is known as Stewart-Treves syndrome. Okay. So I hope all of you are following me. If you're following me, just give me a thumbs up in the chat box. Again, to reiterate, those who've joined in late, the PDF will be shared with you of all the images and whatever is written on the slides. Having said that, please try to jot down the important things which I'm saying, as they would be helpful for your exams. This is part 1 of surgery images. We will at least have 1 or 2 more sessions in which I'll cover the other portions as well. Right. Okay. So thank you for giving me a thumbs up in the chat box. Moving forward, I hope you're still able to hear me. So local recurrence after breast cancer, can be seen, and this is how local recurrence is going to look like after breast cancer. I hope all of you can see me now. You can see the slides, please. Okay, perfect. Sorry for the glitch. So this is local recurrence after breast cancer, and local recurrence can either come as a mass, or you can see that there can be or you can see that there can be multiple small skin lesions. This is known as cancer in cuirass, when the cancer encases the chest wall, and we can detect local recurrence. The best investigation is MRI. Sentinel lymph node biopsy was asked this year also, last year also. It is the first draining lymph node from the cancer, first draining lymph node from cancer. And this is the blue dye technique. This was a case of mine where you could see the dye coming in the lymphatics and staining these lymph nodes. So whichever lymph nodes stain blue in color, they are the sentinel or the first draining lymph nodes. And the dye which we use, this has been asked in the exam, this is methylene blue. Another way of carrying out sentinel lymph node biopsy is using a technetium 99 sulfur colloid. Yes, isosulfan blue can also be used, methylene blue or isosulfan blue, either one can be used. That is correct. So another technique of carrying out sentinel lymph node biopsy is technetium 99 tag sulfur colloid. That is, we inject this radioactive compound, and this gamma camera has been asked in the exam, the image. This gamma camera detects radioactivity. So whichever lymph node is the hot lymph node showing maximum radioactivity, that will be the sentinel lymph node. Mind you, the best technique for sentinel lymph node biopsy is the combination technique, blue dye plus radionuclide. This flap marking has also been asked. This is the latissimus dorsi flap. This is the latissimus dorsi flap, which is based on the thoracodorsal pedicle. Yes, sentinel lymph node biopsy. Some of you have seen my videos. You remember the Chernobyl example which I've given you. Yes, that is the same. So this is a flap for breast reconstruction. This is the latissimus dorsi flap. This was a patient of mine where we done this reconstruction. We take it from the back, we swing the muscle forward, and we reconstruct the breast. But the questions which have been asked, the best flap for breast reconstruction is the DIEP flap. This was again a patient of mine where we did a DIEP flap. This question has also been asked in the exam. DIEP flap is deep inferior epigastric artery perforator flap. That is the best flap for breast reconstruction. Chemoport was asked last to last year in the exam. Chemoport is how we give chemotherapy. So this port is put below the clavicle here, and we just access the port and we can give chemotherapy freely in a central vein. This is a chemoport. You should be able to identify this. It is used for delivering chemotherapy. Now, these images are very, very important. Two such images, one was there in your mid-year exam, one was there in the December exam of FMG. Breast abscess, you will see in lactating mothers, Staphylococcus aureus is the organism, oropharynx of the child is implicated. Clinical features, you will have pain, swelling in a lactating mother, there will be fever. You can see a reddish swelling like this, and the management is antibiotics. If pus is there, you need to aspirate. If that also fails, you will do incision and drainage. Again, for incision and drainage, we use a number 11 blade, which I will show you later. That has also been asked in your exam. Breast abscess image and clinical scenario, you all should be able to identify. This was asked in one of the PG exams. This, they had shown that it was a non-lactating mother, non-lactating lady, and she had more than 1/3 area of Peau d'Orange. I told you, Peau d'Orange can be seen because of blockade of subdermal lymphatics. And if more than 1/3 area of PDO is there, that is a sign of inflammatory breast cancer. So I hope you can differentiate between the two. This was an abscess. It will be typically seen in lactating mothers, right? Whereas this one, non-lactating, it was inflammatory breast carcinoma, and this is T4D on staging, T4D. This was another question which was asked in the FMG exam. You had a 45-year-old lady. You can write in the chat box the answer. Came with a rapidly enlarging breast lump, which was firm, mobile on examination, has a bosselated surface. So, yes, let me see what answers are you giving. Correct. So majority of you are right. The correct answer is phylloid tumor. Is phylloid tumor because you have rapid increase in size. You can see dilated veins here. Look, you can see dilated veins, and it's such a big swelling. Now, phylloids can also be mobile. Fibroadenoma can also be mobile, but fibroadenoma will be a much smaller swelling and there won't be rapid increase in size. Fibroadenoma will be a smaller swelling. It is also known as a breast mouse. Won't reach such a size. There won't be rapid increase in size, and that's how you differentiate between the two. So, thyroid tumor seen in the third or the fourth decade of life, rapidly progressive, lobulated swelling. You will see dilated veins over the chest wall. Uncommon that it goes to the lymph nodes. Only less than 10% go to the lymph nodes. Most common site of distant metastasis is to the lungs, and surgery is we can either do a lumpectomy or we can do a simple mastectomy. Simple mastectomy is done if it is a recurrent phylloids or a malignant phylloids. This was a phylloid tumor which I removed a few weeks back. You can see an 8 centimeter phylloid tumor. It has a bosselated surface. Image of Paget's disease has also been asked many, many times. Paget's disease starts off as an itchy lesion, and you can see that the nipple areola, NAC, is nipple areola complex. You can see that the nipple areola complex is completely destroyed. The nipple areola complex has been completely destroyed. Diagnosis is by a punch biopsy. Diagnosis will be by a punch biopsy. You will see Paget cells in the epidermis, and the management of Paget's disease is the management of the underlying lump. Mondor's disease was also there in your exam, in the mid-year exam. Mondor's disease is thrombophlebitis of the chest veins. And the most commonly involved vein is the lateral thoracic vein. The most commonly involved vein is the lateral thoracic vein, that is Mondor's disease. Again, these two images have also been asked. Gynecomastia is enlargement of the male breast. You can see here both the sides are involved, and it is diffuse enlargement of the male breast. Whereas this was a patient of mine who had male breast cancer. You can see a hard lump here. There, it is not gynecomastia, it is a hard lump. So you should be able to differentiate gynecomastia from male breast cancer on images. Again, I'm repeating these images for breast and thyroid disorders. Every time in the FMG exam, there are 2 to 3 questions, so you should know about them. So that takes care of breast, thyroid, oral cavity, salivary glands. Now I'll be showing you common instruments. At least 2 instrument-based questions are also asked in your exam. So I'm going to show you these instruments. You'll get the PDF where all this would be written. A Rampley sponge holder is used for holding a sponge to clean the area. You can see it has a fenestrated end and there are serrations. So there is the blades are fenestrated and it has serrations as well. These are towel clips. These are 2 types of towel clips. All this is important for the PG exam as well. You have the Mayo clip and you have the Doyen's clip. Both are used for holding linen or holding. Sometimes you would have seen that the cautery is fixed using towel clips. Very important for the exam. This is a BP handle, barred Parker handle, barred Parker handle. And on this barred Parker handle goes the blades. So these are the surgical blades. You put the blades on the barred Parker handle. Blades, the questions which have been asked many times. Number 11 is the stab blade. It is used for incision and drainage. This is pointed. This is a stab blade used for incision and drainage. Number 12 blade is curved. Number 12 blade is curved, and this is for suture removal. This is used for suture removal. All the other blades, that is 10, 15, 20, 21, 22, and 23, all of these are used for making incisions. All these blades are used for making incisions. This is a suction cannula used for sucking out blood or collection whenever you're operating. It is a suction cannula, also known as a Yankor suction cannula. These are skin hooks. Skin hooks are used for breast surgery to raise the flaps or for thyroid surgery to raise the flaps. You can have a single hook or double hook skin hooks. Cat's paw retractor. This is used for retracting superficial tissue. And you can see here that one of the ends is shaped like a cat's paw, which is why the name cat's paw retractor. This retractor, the surgeon or the assistant has to hold themselves, or the nurse has to hold. So this is a non-self-retaining retractor. It won't remain in place by itself. Somebody has to hold it. Zernies also has to be held by somebody. Zernies retractor, solid blade at one side, fenestrated blade on the other side. Solid at one side, fenestrated at the other side, again for superficial structure retraction. Used for retracting superficial structures. Langenbach is just one solid blade at right angles for retraction. This can be used for open cholecystectomy. Langenbach retractor can be used for open cholecystectomy. Morris retractor, you can see Langenbach, I'll show you again. Langenbach had a narrower blade. Morris has a wider blade and a bigger blade. Again, it can be used for abdominal surgeries. I use it for mastectomies. When I'm doing an MRM, we use a Morris retractor as well there. Devers is a question mark shaped retractor. Question mark shaped retractor used for abdominal surgery. That is a Devers retractor for abdominal surgeries. Devers has been asked many times in all exams. Doyen's retractor can be used to retract the bladder. This is a Doyen's retractor. It is more curved, has a broader blade as compared to a Devers retractor. Now, all those which I had shown you previously were non-self-retaining retractors. They won't remain in place themselves. Mastoid retractor is a self-retaining retractor. It has a lock. When you put it in place, it will remain there. So you don't need an assistant to hold this retractor. It will remain in place by itself. This is a Balfour self-retaining retractor used for abdominal surgeries. These two blades will retract the abdominal wall. These are used for abdominal wall retraction, whereas this one will retract the bladder, whereas this Doyen's will retract the bladder. So this is a Balfour self-retaining retractor. This is a Book-Walter self-retaining retractor where you can put this ring and multiple such retractors can just be put in place. This is a Book-Walter retractor. So all these retractors are important for your exams. This one is a self-retaining retractor. Joel's, I've already told you, you need two Joel's retractors, one on each side for thyroid surgery. Needle holder, you will have crisscross serrations. You can see here, there are crisscross serrations and there is a groove as well. There is a groove and there are crisscross serrations so that the needle does not slip out. So that the needle does not slip out. This is a needle holder. Whereas in an artery forceps, you will just have transverse serrations. Here you can have crisscross serrations, and that's how you differentiate. Yes, somebody is asking, Joel's retractor is self-retaining. Joel's will remain in place by itself. It is self-retaining. So you should be able to identify a needle holder. This is tooth forceps. You can see teeth here. So for holding tough structures, you can use tooth forceps. This is a plain forceps. It does not have teeth. so it will not be traumatic. It does not have teeth, so it will not cause damage. It will not cause damage to delicate structures. Whereas if you hold with teeth, it will cause damage to delicate structures. This is plain or non-toothed forceps. For holding vessels, we use a DeBakey's vascular forceps. So DeBakey's vascular forceps will have a horizontal groove like this, and it will have transverse serrations. It will have transverse serrations and a horizontal groove. This is a DeBakey's vascular forceps. Russian forceps is what I use for holding lymph nodes. So you can see that it has multiple small teeth. This is a Russian forceps used for holding lymph nodes. This is a Mayo or a heavy scissors. This is a straight Mayo scissors, which is used for cutting tough structures, used for cutting tissue, used for cutting sutures. I'm sorry. This is a Mayo scissors used for cutting drains as well. Straight scissors. Metzenbaum is curved. Mayo was straight. Metzenbaum is curved. And this is for tissue dissection. This one is for tissue dissection. So this is a tissue scissors for tissue dissection. This is Metzenbaum. Makindo is even finer tissue is Makindo scissors. Very important instruments now. Last 10 minutes is where you will definitely get 2 or 3 questions in your exam. So this is a Varies needle used for creating pneumoperitoneum. Everyone should be able to identify a Varies needle asked at least 10 to 20 times for pneumoperitoneum, okay, during laparoscopy. Once you insert this, then you can push in gas, that is carbon dioxide, through this. This is a sharp laparoscopic trocar. You can see this is sharp, right? This one is a sharp laparoscopic trocar. But you can have a blunt trocar as well. And if you use a blunt trocar, that is known as a Hassan's trocar. Hassan's, you can see, is blunt. Previous one was sharp. This is blunt. All these are used for laparoscopic surgery. These are laparoscopic instruments. Laparoscopic instruments are long black instruments. The black coating around the instrument is insulation. The black coating is insulation so that current does not leak out. The black coating is insulation so that current does not leak out. This has also been asked. This is SIL, single incision laparoscopic surgery port, where through one port you can put in 3 instruments and you can carry out surgery using a single incision. Very important for your exam is robotic surgery, and this is the Da Vinci robotic system which is being used these days. This question has also been asked in your exam. The Da Vinci robotic system is being used. Humby's knife, at least 20 times in the exam this has been asked. Humby's knife is so this is a Da Vinci robotic system for robotic surgery. And this is the system, robotic system, which we are using. You should remember the name Da Vinci robotic system. Humby's knife has been asked at least 20 times in the exam. It is used for raising skin grafts. This is a Humby's knife. It was asked last year as well. You people should be able to identify it. Very important. Euro bag for urine collection. All of you know it is a bag which has all numbering. You can measure the amount of urine which is coming there. But you should know a chest tube bag or an underwater seal bag as well. Chest tube or underwater seal bag. I want you to appreciate the difference between the two. A chest tube bag, the tube is running right down till the bottom, and it is triangular from the bottom, and there is a mark till which you have to fill water. So the end of the tube is submerged underwater. End of the tube is submerged underwater, and the reason for this is that if air comes out, air can bubble out, but air will not be sucked inside again. Air will not be sucked inside again. So you should be able to identify the underwater seal bag. IV lines, very, very, very important. Every FMG exam, there is a question from IV lines. You should know the color coding. Color coding will be there in the slide which you get tomorrow, the PDFs. Orange is 14, gray is 16, green is 18, pink is 20, blue is 22, yellow is 24. The thickest one is orange, the narrowest one is yellow. So obviously orange will have a faster flow rate. So if a patient is dehydrated, you put in the thickest possible cannula. If you want to give fast fluids, put in the thickest possible cannula. This is thrombophlebitis, which is the most common complication following IV line insertion, which you should know. Most common complication following IV line insertion is superficial thrombophlebitis. Foley's catheters are also asked in the exam. The French in Foley's, what do you mean by the French in Foley's? It means 2 pi r, that is the outer circumference. The outer circumference is French or 2 pi r. Remember that a rubber Foley's is good for 7 days, then you need to change it. This has been asked in your exam. And a silicone Foley's can be kept in place for 30 to 35 days. You should remember the color coding. White is 12 French, green is 14 French, orange is 16 French, red is 18 French. Three-way Foley's. Three-way Foley's. Three-way Foley's is used for clot retention. If there is clot retention, we use a three-way Foley's there. And the French in Foley's is outer circumference or 2 pi r. This is a Riles tube. All of you should know about Riles tube. Last year in the exam also it was asked, what is the length of the Riles tube? How do we measure the length? So we measure the length from the nose to the ear lobule to Ziffy sternum. That is how we measure the length from the tip of the nose to ear lobule to Ziffy sternum. That is how the length is measured. And the length, and we have to insert the tube. The best position to insert the tube is when the patient is sitting with the neck slightly flexed. Sitting with the neck slightly flexed. Foley's, three-way Foley's, you can see 3 channels here. One is for urine to come out, one is for the balloon, one is for irrigation. And three-way Foley's is used for clot retention. When there is a clot and you want to push out that clot or retention is there, you will use a three-way Foley's for irrigation. So these are the slides which I wanted to show to you. I will share the PDF with you. Just want to share some new initiatives which Marrow is taking for FMG students. The clinical subject Q bank, all the clinical subjects would be live in 2 to 3 months. Currently, medicine and pediatrics is live. As and when subjects are getting updated, you can see FMG specific questions in the Q bank. Videos will also be available under the FMG tag very soon. You don't need to switch for videos, and we will have mock tests before the June exam. How do you go to the FMG mode? So you go on the settings in your Marrow app and click on course. You click on course. And when you click on course, there will be an option of FMGE Q bank. You can click on that and the FMG Q bank will open up. And the FMG Q bank is going to open up. So that's how you move from to the FMG Q bank. Even till your June exam, I will have 1 or 2 more image-based sessions in surgery. Pathology session will be held in the next 10 to 12 days. Dr. Ila will be taking a session on pathology where a lot of images were asked. And Dr. Sakshi will also be taking a session on obs and gynae next month. Okay. So exam date is 18th June. All of you should start your planning and implementation. Currently, 60 to 70% of your time should go on reading notes or watching videos, 30 to 40% on MCQs. In April and May, it should be 50-50. 50% time notes, 50% time MCQs. Don't forget to do MCQs. This is very important. That is what is asked in the exam. You need to do MCQs. At least 40 to 50 MCQs have to be done in February, March per day, and by April, May, 80 to 90 MCQs. 3 to 4 grand tests or mock tests. Marrow will be organizing those mock tests. Don't forget to revise images. Images, there were so many images in your exam. Every day, at least 15 minutes, revise images. If you can do that, trust me, you will not fail the exam. You can crack the exam easily. So revise your images, please. Look at the finer details of the images, right? This is another picture which I clicked. Look at the finer details. And if you can remember these images, you will easily crack the exam. Okay. Let me just take a few questions before I wind up. We will try to identify sessions for medicine and pediatrics as well. These are my contact details. If you have any questions, you can message me on Instagram. My ID is left-handed surgeon. Next exam, we have no update right now. I don't know about provisional, whether with provisional graduation you can give the exam or not. That we'll have to see. I've already covered the strategy for the exam with all of you. Perfect. Thank you very much. We will try to do more sessions for NEET PG as well. All the images you will get tomorrow. Video lectures are already there in the Marrow app. Right now you have to switch. Within 1 month, you won't even need to switch. Okay. I will tomorrow with this PDF, I will send the important topics in surgery also. Okay. This is for FMG, PG, everyone. These slides are important. So this session was mainly for FMG students, but even if you're a PG aspirant and you're attending it, you will benefit from it. Okay. Thank you very much. Thank you for joining in, and we will send you the PDFs tomorrow. Keep studying and make sure you crack the exam, and definitely send me a message then. Okay. Take care.
Thank you so much, Dr. Rohan, and for such a nice session. And thank you so much, everyone, for joining us today. And we will be sending the PDF and the slides by tomorrow, as said by sir. And we'll be having more sessions, and you will be intimated before the sessions, just like we did this time. Thank you so much, everyone.
Thank you.